because I'm luscious. Yes, that's right, yes, I'm luscious. I'm luscious, and I'll sure be good to you. They used to call me Fish, but now they call me Lou. When I make my music, I started with a rule. I took a little song, and then I begins to smoke. I put this trombone up, and then I played it till it broke. 'Cause I'm luscious. That's right, yes, I'm luscious. I'm luscious, and I'll sure be good to you.
That big mic. too.
I think mine is live.
Is it? Are we live? Guys, we're live. Welcome to the MLI, that's the Medical Learning Institute Symposium. Thank you for coming, and I hope you're enjoying your meal. There is a free bar in the back. So if this gets boring, please visit the bar. These are some housekeeping things I'm supposed to read. The title, it's Detection to Treatment. We're going to talk about all aspects of NTM. And I'll let my colleagues introduce themselves in a second. I'm Dr. Kevin Winthrop from Portland, Oregon at Oregon Health Science University, where I'm a professor of infectious diseases and epidemiology. Shannon?
I'm Shannon Kasperbauer. I'm coming from Denver, Colorado. So I practice at National Jewish Health, where I was just promoted to professor.
It's about time.
Good evening, everyone. My name is Dr. Rocio Hurtado. I'm based in Boston at Mass General, where I direct the Mycobacterial Center. And it's wonderful to be with you tonight.
Great. I'm glad you introduced yourself because I was very worried I was not going to pronounce your last name as well as you did. These are a few things before we get started. There will be live polls, like a lot of them, throughout the session via Mentimeter. A QR code will be displayed on the screen for you to participate. So we're going to start by scanning a QR code. At the conclusion of the symposium, you will be also shown a QR code, which will take you to another QR code. I'm just kidding. Upon completion, you will be prompted to download your certificates for your continuing education credit. And I think I get to just start advancing slides here. That's us. And thanks for coming. Learning objectives. Assess the incidence and prevalence of NTM lung disease. So the epi of NTM lung disease. We're going to talk about diagnostics. We're going to talk about treatment, talk about refractory disease, and then talk about a little what's on the horizon in terms of the pipeline. So that's your first QR code. Please scan it because I think that puts you into the poll. And we want to thank our friends from Mentimeter. I'm just kidding. And then you should see a first polling question. If you were a respiratory clinician in Thoracic Park, which dinosaur would most likely need your help first? A T-Rex, a Velociraptor, a Brachiosaurus, and Triceratops. And there's some reasons why you might choose one of those, which are written there. So you can digest those and then select your answer. And I think your answers are going to pop up. Huh. Okay. A lot of people have a long neck and a long airway, big problems. You're right. That would be the one that you'd probably need to help first. And we don't really care about the allergy people and the T-Rex. Okay, so that was fun. That was really just to get you going. What word comes to mind when you hear non-tuberculous lung disease? So this is the word salad. And what's it called?
Word cloud.
It's a word cloud. Kind of looks like a salad. Yeah. Anyway, whatever word you put in, the most that people put in are going to be the biggest words. And then I'm going to ask Rocio to talk about the words.
So a lot, structural lung disease with bronchiectasis. I see a very big theme of debilitating and chronicity to these elements. Difficult. So this is really hard and long. Shannon?
I agree. I mean, I think that this just emphasizes that we're treating two diseases, not just NTM infection, but bronchiectasis as well.
I see the word astronauts getting slowly larger. Whoever put that in, I think it's Ed Chan. Where's Ed? I don't know. Anyway, chronic and annoying. I was in the gym at the Fairmont yesterday, and there was a lady who's a nurse, and she's 45, and she was coughing. She kept working out. She's coughing. She kept telling people, I don't have COVID. Don't worry, I have a chronic cough, chronic lung disease, and no one knows what it is. And I listened to her for an hour coughing, and I went up to her and I said, I know what you have. And she said, what do I have? I was like, you have bronchiectasis. And she said, what's that? And I was like, well, I told her what it was. And I was like, have you had a CT scan? She said, no, my doctor doesn't need one because my x-ray is normal. So there you go. So we're going to talk about bronchiectasis tonight, but she needs a CT scan, and I'm sure she has bronchiectasis because she sounds like every single patient I have, with or without NTM lung disease. But suffice to say, it's underdiagnosed, and it's why we're all here tonight to talk about it. So we'll talk about the incidence first, and it doesn't matter where you do the study. And the studies on the right, we did this with a database that's nationally representative. It was commercial claims data. We looked at Medicare data. And it doesn't matter if you look at men or women, and I'm colorblind, so I can't tell you what any of the lines are, but they're all going up. And it doesn't matter where you are in the world, what study you look at in the last 15 years, incidence and prevalence is going up. Some of that's detection bias. We're doing more CT scans, whatnot, but I think we all think it's real, right?
Yes.
Indeed.
There's some aspect to it that's absolutely real. And it has to do with the environment or more susceptible people out there in the population, I think. There are some hot spots. We think about Hawaii and California as probably have the highest incidence, but you can see this map here. It seems to be where it's hotter and more humid, except for Arizona there, where it's really a bunch of old people. Well, in Florida too. This map is driven by the age of the population as well as probably environmental distribution of NTM, where we see, Ken and Olivia did a study a few years ago. They correlated NTM prevalence in humans actually with the amount of water vapor in the air. And there's other studies looking at different environments. And we know historically the Southeast has been a place where a lot of people have false positive skin tests. We've always thought there's a lot of NTM there. And I think this map is probably about right. I don't know. Do you guys agree?
Well, it's also looking at a really vulnerable population. So this was in the VA database where they were looking at patients with COPD and a diagnosis code of NTM. So we're already underrepresenting, right?
Yeah.
NTM lung disease. We probably are coding for maybe 30% of what's actually really out there. But look at these rates of period prevalence. I mean, they're in the 400 per 100,000. So hugely vulnerable population.
Yeah, good. CDC NTM surveillance. This is a fantastic project that's probably been canceled now by like everything else. But it's something. I used to work at CDC years ago, and we wanted to do something like this. It took about 20 years to get enough interest and then some funding to do it. But it's a emerging infection program pilot where there are a number of emerging infection program sites around the country, and they're population based. They collect pathogen data from labs or in some cases from individuals. And they look at certain things like, invasive group A strep and other bugs. But they added NTM to this a couple years ago, and it's been great. They've actually shown the incidence and prevalence of the disease, both extrapulmonary and pulmonary. You can see the incidence, annualized prevalence is basically like incidence. It's 6 per 100,000, which is exactly what we found in Oregon data a few years ago when we looked population-based fashion. It's kind of the people we see in clinics. It's mostly female, mostly white. And these are, based on culture data. So you get a culture and the nurse calls the doctor and looks through the chart and applies the ATS case criteria and determines who's a case. And this is what they're finding. So, and most of it's MAC, 72, 75%, maybe a little lower than what we would have expected. I kind of see more like 80, 85% MAC. But what do you guys think?
Yeah.
Yeah.
No. And just a reminder that the rates of TB in this country are 2 to 3 per 100,000. So across the board, we do see a lot more NTM. And thankfully for TB, the overall rates here in the country, not being a an area of intense transmission, you don't see the rates of reinfection that we see. So I call our NTM patients our friends for life because we tend to see them for life.
Mm-hmm.
Right. We're going to talk about relapse and reinfection in a little bit. This is my question. I guess you guys are supposed to comment on this, but how do risk factors associated with bronchiectasis, COPD? Well, we've mentioned both those, and asthma influence prevalence. Shannon, do you want to expound upon the risk
Sure.
factors?
I think it really, like I said earlier, I think it's really hard to find a patient with NTM lung disease that doesn't have bronchiectasis. These are, like I said, two diseases that are married. And we know that those patients with COPD and asthma particularly are at higher risk, and then adding their treatment to their risk profile. So a lot of these folks are on chronic inhaled corticosteroids or potentially on systemic steroids or other biologic therapies that would increase their risk.
Indeed. Yeah. There was a recent meta-analysis in chest in the last year that revealed all that Dr. Casper Bauer has mentioned. And yep, 4 to 6-fold higher rates in COPD and asthma, bronchiectasis as high as 20-fold, et cetera.
Yeah, we did a study a couple years ago. Someone asked me after we were drinking beer after a couple hours, they're like, what % of people with bronchiectasis get NTM? And I was like, wow, that's a great question. So we went to some of our population-based databases, and we figured out that if you get this is Medicare data, so it's US data. It's based on a code given by a pulmonologist. But if you're diagnosed with bronchiectasis by a pulmonologist, the rest of your life, you have a 1.5% chance of acquiring NTM. So, if you're 45 or 50, by the time you're 70 or 80, you got a pretty good chance. It's 50% or something. So it is a cause of bronchiectasis, which, we could talk about more, but it's also people get pre-existing bronchiectasis and, of course, acquire the MAC. The other thing I just mentioned is interstitial lung disease, rheumatoid arthritis. I mean, there's some other forms of fibrotic lung disease, any structural lung disease. We can see people acquire NTM. Certainly bronchiectasis and COPD, or I would say smoking-related lung disease, emphysema. We always talk about COPD, but let's face it, most of our bronchiectatics have some mild and moderate obstructive lung disease. And they get labeled as COPD, but really when we have this up on the screen, we're really talking about smoking-related emphysema. Do you
For sure.
Yeah.
And bronchiectasis will beget obstruction as well over time.
Yeah. Okay. I think this is.
Yes.
Yeah.
And so these organisms are ubiquitous in the environment. You cannot escape them. In fact, there are large-scale studies that have been done by Dr. Falkingham and Richard Wallace showing that there's about a 50% match with some of the water sources found in homes, in particular related to shower heads. There are over 200 species of NTM that can cause human disease. 30 are the most common, of which there's a much smaller list as well, with avium, M. abscessus, and Kansasii sort of being the top 3. And there's some regional differences as well. And as Dr. Winthrop mentioned, a very large rate in incidence and growing incidence and prevalence in the U.S. each year. And globally, really the tip of the iceberg, a lot of countries don't actually do surveillance. Many countries, including 2 of the countries I work with, have very limited microbiologic infrastructure to determine if mycobacterial growth is related to NTM. Many of these patients, I was talking to Shannon before, get misclassified as having potentially drug-resistant TB. And the cycle of lung destruction continues because they cycle through TB regimens ad nauseum. And there is a growing recognition that post-TB bronchiectasis can affect anywhere from 50 to 75% of patients, and many of those patients go on to develop bronchiectasis, NTM as well. There is a spectrum of disease. There's some of these isolates, for instance, Mycobacterium gordoni, which are much more often to be lab contaminants, and there are others at the other end of the spectrum, like the Zolgais, the Xenopes, the Malmoense, which are much more predictive of disease as well. When you sort of see the phenotypes or the morphotypes of patients, I used to have a nurse who would stand at the outside of a very diverse ID clinic at Mass General, where we'd see HIV patients, tropical medicine patients, and that nurse could always identify who the patients were who were coming to see me. With literally 95% accuracy. So you'll have your patients with COPD, typically bullous emphysema, who oftentimes have cavitary disease or smokers. The other phenotype in men are those men who are chronically aspirating and have sort of more dependent disease. And then you have your ladies who typically tend to be taller, leaner, typically of Northern European ancestry, that are the Lady Windermere's with fibronodular bronchiectasis, and associated also higher rates of chest wall deformities. You see a gentleman here with pectus, scoliosis, mitral valve prolapse. So these are all part of the morphotypes. And there are many copathologies. Many of you are aware, very high rates of dysmotility and GERD, silent aspiration, and oftentimes some of these radiographic findings can be overlapping. and also really tackling some of the other underlying etiologies and associations, especially amongst those who are living with bronchiectasis, CF and non-CF, is truly key. I have a couple of pictures here of some of my patients. There are other co-infections that are not uncommon, so semi-invasive and mycotomas, especially at sites of old cavities. There's actually a risk of malignancy in certain studies, squamous cell CA from the chronic, at areas of chronic inflammation, and a little smaller signal with adeno-CAs as well. And then about 5 to 10% of patients will have dual NTM infection. The most common combo in this country is MAC and M. abscessus. And so it's a very dynamic group, shall we say.
Yeah. No, I'd say we recognize that more and more, particularly, I mean, those of you that treat it, you start targeting MAC, for example, and then 6 months in, they're growing abscesses.
Yes.
And you don't always know what to do about it. Shannon, what do you do about it?
Well, it depends. If a patient, you have to stop, right? Not immediately put a patient on 5 or 6 drugs and just look at the big picture. Usually we will continue to get cultures, make sure they're consistently growing that Mycobacterium abscessus, and then repeat imaging to see if there's any evidence of radiographic progression. If patients are clinically doing well and there isn't evidence of progression, and certainly if they have a macrolide resistant abscessus, I don't sweat it and I treat their MAC.
Yeah, good. Patient yesterday, was it Friday or whatever, 2 days ago, I mean, she has cavitary MAC, and she just said, hey, is it going to shorten my life? So a couple years ago, we didn't have any data, and this is data, Ted Maris did this in Canada, we did it in Oregon, a few other people have looked at it, and it's pretty clear that actually it is going to shorten your life by 20% or something in terms of your 5-year mortality numbers. So you see a hazard ratio 1.37 our data, 1.2 in Ted's data. So I mean, I think though you can reassure patients and tell them if you do something about it, and if you work hard and are willing to, it's a hassle to deal with it, but you're probably not going to shorten your life. But if you don't, get into care soon enough, I mean, some people like this woman I saw, I mean, it's too bad she wasn't seen, last year, but she got a huge cavity, and I'm not sure she's going to be able to resect it. And I think it probably will shorten her life, which is too bad because she's someone who has nodular bronchiectatic disease, and I'm sure it's been going on for 10 years. And if someone had picked it up earlier, it wouldn't be an issue, or it'd be less of an issue. So another bubble dialogue I have been tired and generally weak for several years without an explanation.
Sounds like us.
Yeah, we have been too. Yeah, I actually have multiple explanations. I recently found out I have GERD. Well, did I write this about myself? Which I've noticed a lot of others with NTM mentioned. So it seems like it might be more connected than I thought. Okay, I'm asking Shannon because they're big on GERD at National Jewish. Shannon, what do you got on GERD?
Well, it's clearly related, especially if you have that patient who has basilar disease. They have that dependent nature disease. And I think it in all of our patients with bronchiectasis, I think we're really missing the boat if we don't stop and work up their bronchiectasis. So, we and others at other institutions, we have sort of an algorithm of things that we look at, and routinely we'll look for reflux disease. How to best do that, I think, is, under debate, but there are many patients who have silent reflux. And if we don't get that under control, I mean, we can treat them for years with drugs, but if they continue to soil their airways, then we've really missed on that patient.
Yeah, you should not soil your airways. That's, I would say the thing I'd add to that are there's certain bugs that make me think of GERD. M. fortuitum, number 1. M. coloni, number 2. Random weird species that you've never heard of. That's GERD. I mean, a lot of those people, you look at their CTs, they got a big, thickened, ratty looking esophagus, and they're growing weird bugs out. Yeah. A lot of those non-pathogenic bugs, or Sia was mentioning, I mean, that's pretty much usually GERD. Certainly someone who grows MAC every day for 5 years, that could be GERD too, but I do tend to see more diversity in the NTM. Do you agree with that? Yeah.
Yeah. And then the other thing is there's sometimes patients who will grow numerous, maybe in March they grow MAC, abscessus, they then grow a fortuitum, they grow a Gordoni, that also, in addition to GERD, also points that they're probably not optimized on the airway clearance front.
Shannon, this is your slide. What do you think about hot tubs? You
Let
love
me
them.
start at the top.
Yeah.
So this slide is just, again, emphasizing the risk factors. So any kind of underlying architectural abnormalities. And getting back to this evaluation for bronchiectasis, I would also argue that we should probably do a sweat test on all of our patients. I mean, we've diagnosed people in their 80s with adult CF. So I would start with a sweat test in all patients and then pursue genetic testing if the sweat test is abnormal. Rheumatoid arthritis, interesting, by itself, without the biologics, is a risk factor for NTM lung disease. Having prior tuberculosis, as Rocio said, and reflux. And then again, we could spend all night talking about the environment, and this is a really hot topic for patients because they want to avoid getting this infection again. So we don't really know. That's, I think, why there's question marks next to each of these behaviors. But if someone is an avid gardener, maybe they're at increased risk. I mean, there's been population studies, and Rachel Thompson did a lot of this work in Australia, looking at people who were near or working in areas of agriculture were at higher risk of having NTM lung disease. And then the hot tub question. So a lot of patients ask me if there's anything that I should avoid, what is it? And I just say, you know what? This is a spectrum of risk. I don't want anyone to feel like they need to live in a bubble. But if there's high risk environments, hot tubs are one of them. So there's also population-based data to suggest that indoor pool exposure is another risk factor for NTM lung disease. So I tend to tell my patients, no hot tubs, try to avoid indoor pools. If you're a swimmer, and I have avid master's level swimmers in my program, I encourage them to try and swim outside. And then I think the last one on that list was CPAP. So again, good practices to tell your patient to use distilled water, proper cleaning techniques of their CPAP machine. But I don't tell people to stop using humidified CPAP.
Yeah.
Sort
I
of,
actually tell people to boil their distilled water because we did a study years ago where we grabbed distilled water off the shelf at the grocery store, and we grew NTM out of a number of them.
Yeah.
It's not sterile. And so I always tell them to use distilled water, but I tell them to boil it. And maybe that's overkill, but
No.
probably
Boil
practice,
all the way
yeah.
here. Yeah.
So next question, are there any under-recognized or emerging risk factors for NTM lung disease that deserve more attention?
Rocio?
I would just highlight the CF testing in addition, not just in addition to the sweat chloride. Many of our patients, bronchiectasis registry and other studies, anywhere from 15% to, in some series, 40 to 50% are heterozygous for the CFTR. And now in this new era of the targeted therapies, we are using, before it used to be almost an academic endeavor to detect heterozygosity, but now there's an actual management implication as well. But we do periodically run into snags with insurance and testing. So Shannon, I'm wondering what your tricks are.
Yeah. Well, I mean, certainly it's who you contract with.
Yes.
But our Medicare patients, it's $250 out of pocket cost. So
Yep.
You
depends on the
cancel ahead.
individual, but we
Yeah.
just counsel them that that's what that will cost if they pursue genetic testing.
Yeah.
Yeah, the only thing I'd add to the list is just immunotherapies. There's just slews of new biologics and targeted synthetics coming out, and a number of those MOAs increase the risk for mycobacterial disease. So it's kind of something I'm interested in and kind of keep track of. But there's more and more risk factors, and it's hard to keep track of all those things.
Exactly.
I did feel a QR code coming on, so I guess hit it, and that's a polling question. What is your biggest challenge with diagnosing NTM lung disease? Differentiating from other lung diseases, specimen collection, interpretation, applying guidelines, patient follow-through adherence, access to expert consultation, or something else. I think the astronaut's going to pick F. What do you think? Let's see what we got.
Can you see the different colors?
I can't see any colors, but I do see the percentages, and it looks like adherence and follow-through is kind of number one. Shannon, do you have thoughts on that? I know we're going to get into that a little bit, but
Yeah, no, it's a lot. Patients have been coughing for a long time, and then you sit down and say, here's the regimen. It's 3 drugs for anywhere from 12 months to 24 months, and not everyone's going to get cured, and they often come in and they say, gosh, I'm just so glad I didn't have TB. We say, you'd be much better off if you actually had TB. Yeah.
Is that what you said?
Indeed.
Yeah, I wish you had TB too.
TB.
Yeah, no, you're right. It'd be a lot easier to treat, and you can cure it. So it's hard for patients. That's why we don't often start therapy right away, because it takes some time to educate, get someone to do an airway clearance or whatever, and get them to wrap their mind around what they're going to have to do. Don't you agree? I mean, I often
Absolutely.
don't start right unless they got a cavity and they're sick. I mean, I take weeks to kind of get things going. Anyway, we're going to talk about, I think Shannon's going to go into therapy and how to start it. And first we're going to talk about diagnostics. Oh, delayed diagnostics and how can we avoid these common pitfalls. So I think, Shannon, do you want to just start
Sure.
with diagnosis and hit?
Yeah, so really the first step is, as the clinician, you have to think about it, right? And so this gets back to the nurse that was in the gym with Kevin, who has a chronic cough. I mean, a lot of our patients have other symptoms in addition to cough. Maybe they're having low-grade fevers or they're having some weight loss. Those red flags warrant a CT scan. And we will often miss this on a chest x-ray. So really, truly, a chest x-ray is not the diagnostic tool of choice. So once you see the CT scan and you're suspicious of NTM lung disease, you have to collect specimens. And really teaching your patient how to collect specimens is important. Some patients will come to us and say, I just don't bring up any phlegm. So then what do you do?
I bronch them.
No, you do.
No, we try to do home induction. If they have a nebulizer and saline, we try to get them to home induce. If they don't succeed, we'll bring them in and induce them. And if we still don't succeed, we'll probably do a bronchoscopy. But I don't know.
And do you do that too, Rocio?
Yes,
Master
yes.
Earl? And I think we're so lucky at academic centers where we have this, expertise within our RT program to do that. But for a lot of community docs, that's really a barrier, is getting them to perform a proper induced sputum. And then after you collect it, it will go to the lab. We'll perform a microscopic examination with a smear. Then it's set up in culture. Depending on your lab, they may use just solid medium, they may use just liquid medium, or they may use both. And then there's the identification and ultimately the drug susceptibility. And for all of us who want to get an answer quickly, this is humbling because it can take weeks or months. So the first step is really to think about it, and we recommend that you collect ideally 3 specimens and try to space those out by a little bit of time. So typically we will, space those out by a week at a time rather than doing them back to back. And why is it important? Well, disease progression occurs in the majority of patients. So up to 60% of patients who meet the diagnostic criteria will progress within 3 to 5 years. We know it's associated with lung function decline. And as you heard earlier, 5-year all-cause mortality can be as high as 10 to 33% compared to controls. And it's higher in those that are untreated versus treated. So the next panel discussion is, when making a diagnosis, how do you interpret conflicting microbiologic or radiographic findings, such as a positive culture, but maybe no clear radiographic disease or just mild disease?
I think this is a real scenario that plays out in clinical practice. And I think it speaks to the fact that there are many roads that lead to Rome. For example, you can have mixed pictures with aspiration leading to trachea bud opacities. Patients get misclassified. They may have underlying COPD initially, and then over time they get colonized or asthma. And it also speaks to the fact that we can't make these assessments in a single sort of, we can't just come down with a Solomonic pronouncement and then release people out to the world and see them in 10 years. Those are the folks who get into trouble. So these really are assessments that are made over time and serially. And I think in the current era where, visits are short and these are chronic patients, it just adds to the complexity, I think, as a healthcare system as to how we manage and follow these patients, because oftentimes over time, and as we're collecting specimens, as we're sort of managing the comorbidities, the picture will become clearer.
Yeah, I would just add to that. I liked what you said. I think it's that repeated assessment. It's huge. I mean, people with bronchiectasis might be overkill, but I know the risk is 1.5% per year. I collect sputum every 3 months, every 3 to 4 months. I mean, they, to me, are under surveillance forever. I mean, that's what I try to do if I can. I mean, if you find NTM once, like, keep looking for it. I mean, if you keep finding the same one, then they might meet disease criteria. Maybe they have maybe they have a pretty normal CT scan, but they won't in a year. I mean, we see MAC cause the bronchiectasis, right? So I think you just got to have that repeated assessment idea or mentality.
Yeah.
So the NTM diagnostic guidelines take into account this syndrome, that you really would like to see clinical symptoms, consistent radiographic features, whether or not that's nodules and bronchiectasis, as you heard, or cavities and more severe disease. And the microbiologic piece to this is what we've been talking about. It's getting repetitive, consistent data with the same organism. And so these diagnostic guidelines in the 2020 publication really didn't change when compared to 2007. But what they did suggest is that you ask for species level information. And this gets back to what Rocio was saying earlier. In a patient who in January cultures avium, and in February cultures intracellular, and in March cultures Mycobacterium timidens, they're all MAC, right? And if your lab was just telling you that they had MAC, you'd probably start that patient on treatment. What I'm challenging you with is, would you start them on treatment if you knew that these were 3 completely different species? And I think the answer there is no. So I think we as providers should be looking at our resources, our contracting with labs, and trying to get the best information to service our patients. And then once you make the diagnosis, that doesn't mean you automatically start treatment. As you heard from Kevin, we will oftentimes just teach the patient how to do airway clearance. We'll work up their bronchiectasis. Those are the first really important steps when you first meet with a patient. The next slide talks about bronchoscopy versus sputum. So we see this a lot where patient has a bronchoscopy and they're diagnosed with disease, because we will take that as a qualifying criteria that they have disease if there's one positive bronchoscopy. But I would just say that usually is when I push the pause button. I meet with the patient. I teach them how to do hypertonic saline. I try and get additional sputum to corroborate that evidence. And certainly if they have mild disease, maybe you've made the diagnosis, but there's not an urgency to start them on treatment. And bronchoscopy is probably not as good as you think. So we use lidocaine oftentimes in those patients that are coughing a lot, and lidocaine can be bacteriostatic. So although it's rare, we've had patients that have a negative bronchoscopy and then 3 positive sputum induction. The specimens dilute. There can be sampling error. We're unable to determine the bacterial load, and then of course there's minimal risk and costs. Whereas with sputum induction, we can get multiple samples over time, and we've met two goals, right? We've all taught the patient how to do a therapy at home, and we're able to get cultures. And we know that smear positivity and the number of positive cultures are associated with progression of disease, and there's similar yield between sputum induction and bronchoscopy in TB and in NTM lung disease. So I encourage you to look at your resources and try and teach your patients how to do this at home. Other considerations for initiating treatment are here. So as you heard, Mycobacterium fortuitum, highly associated with reflux and aspiration, or oropharyngeal dysphagia and aspiration. So that's almost never an organism that we treat in clinic, and we would work up the aspiration syndrome and teach that patient how to do airway clearance. Looking at the resistance pattern, if you have a case, of, for example, of Mycobacterium simiae, where they are only sensitive to 1 or 2 drugs, you may, again, not start treatment and just pursue airway clearance. There are 2 characteristics here that we would recommend, and this was addressed in the first PICO question in the guidelines, where we would definitely recommend treatment. And that is someone with high burden disease, as defined by being smear positive or having cavitary lung disease. Host predictors for progression. So a host that's immunocompromised. And I would put into that category a host with a low BMI. Those are immunocompromised individuals. And I think we get so used to seeing people that are underweight in our program, but that's a treatable trait. That is absolutely something that we should be engaging our nutritionists and working really hard on weight restoration. And then the number of drugs, the duration of drugs, the outcomes, and the risk for recurrence are all considerations that I think, this takes a lot of time when you're meeting with patients. And oftentimes this information is overwhelming and you haven't even started talking about the drugs. So oftentimes it's good to chunk this out and talk about the bronchiectasis first, get them on airway clearance, bring them back in 4 weeks and look at the cultures and then talk to them about starting treatment.
We're going to talk about success and recurrence in a second. Am I the triangle?
These are mine.
That's yours.
These are mine.
Your triangle.
So just to give you a sense, so this is a lady, and I have not disclosed to neither Kevin nor Shannon who these are. So this is real time. This is a lady who was originally seen. She's in her 40s, mid 40s. Was originally seen at a hospital in New England, a different hospital, and is actually from Mississippi. She has a history of multiple recurrent bronchosino-pulmonary infections dating back to childhood, and then was a military family, lived in many states, so a little bit of fragmentation of medical care, and then sort of settles in the main area and presents to her PCP initially with a chronic cough. And then eventually, when she starts having hemoptysis, gets segued to pulmonary, where she's noted to have underlying bronchiectasis and cavitary disease. These are the CTs. So Shannon, any initial preliminary thoughts on how you would work this patient up?
Any infertility in the patient?
Great question. 3 kids.
Mm-hmm. Any family members with infertility?
No known family members with infertility, but does have a younger sister who wasn't quite sickly as she was, but who has had her fair share of some recurrent
So
bronchitis.
why are you asking, Shannon?
Well, because I think she has CF. That would be something high on my differential diagnosis with her upper lobe disease and presenting young in life. And I always tell the fellows, like, anyone that's premenopausal that comes into our clinic is an anomaly. There's something in their genome that is awry, right? I mean, they either have alpha 1 or CF or PCD, and we should be looking really hard to figure out what is their genetic susceptibility in a 40-year-old.
Yeah.
This did not start yesterday. This has been going on for years to have this severe bronchiectasis.
So hold on.
Is there more?
Yeah, there's a little more.
Okay.
So she's ultimately diagnosed with, I'm just going to throw some themes to sort of, 'cause this is going to come up later. Gets started, has cavitary disease, gets started on 3 times weekly, not by us, 3 times, Shannon is making a grimace, she's grimacing, 3 times weekly azithro, rifampin, and ethambutol, and is also eventually growing aspergillus. Mm-hmm. So just to bring up some other themes, is ultimately, by the time she gets to us, diagnosed with cystic fibrosis, and then starts having massive hemoptysis and has to be co-managed. I'd mentioned earlier themes around co-infection. So
This is where I think a bronch is helpful.
yes,
Right. This is, I'm not a pulmonologist. I'm not an operator, but I really do rely on my colleagues to get a bronchoscopy if I'm worried about concomitant infection.
absolutely. And she had targeted bronchs, and it was very interesting because she ultimately grew MAC M. abscessus, and she had semi-invasive aspergillus, and they were not all present and co-present. The cavity had combo MAC and aspergillus in another area. It was very interesting. So she ended up ultimately developing bilateral upper lobe disease and medically managed, but underwent a bilobectomy over time and has been cured.
How'd you decide she had semi-invasive aspergillus?
She actually had
Had a
a
biopsy?
biopsy.
Yeah.
Yes.
Cool.
Yes. Had a lot of issues with QTC prolongation on like 5 different QT prolonging medicines, but we were able to manage.
So another case?
Another case. This is a gentleman from Southeast Asia in his 60s with a remote history of tuberculosis while in Southeast Asia. The details were a little fuzzy because this occurred while he was in his 30s, so he could not recall, but he thought maybe on the right side, didn't have the original films. And he presented originally with a chronic cough and hemoptysis. Kevin.
Well, certainly you want to rule out TB first, which would be the usual. It certainly could be relapse of his TB, absolutely. But certainly he could now have MAC or abscessus or something else in the area of prior TB, which is something we see, which you've mentioned. In fact, we did a study once. It was about 5 to 10% of people in the U.S. who had NTM. Well, this was Oregon. It had some sort of history of TB, which is probably higher than the usual, but it just speaks to the fact that it is a common risk factor. This is a guy you can probably get sputum on. I'd go with 3 sputums, like over 3 days, or 3 in a week, something like that, like Shannon mentioned.
I think if you're working up TB, that would be someone I'd probably try to get quickly, right?
Yeah, we'd probably do it in 3 days. I mean, but they'd probably be in isolation at home for a few days until you can get their smears and see if they're infectious and whatnot. So I'm assuming he didn't grow TB because he wouldn't be in this symposium. Is that right?
Yes, he didn't, although he was empirically treated. He was managed elsewhere.
Yeah.
Was it folks anchored on the TB thing? He was on 2 months of TB, not getting better. Ultimately, interestingly, at the other place, he was bronchhed and was found to have pulmonary alveolar proteinosis, which is a risk factor for NTM, and grew MAC and M. abscessus, and had biopsy from both biopsy and bronch.
Wow.
Yeah, so he's got a lot more going on than just post TB. Just a comment on that is that you do get these people, and they're relieved when they find out they don't have TB. Although Shannon already said
Yes.
it probably would have been better. It speaks to the fact they don't get better on ripe. Thiametol and rifampin together do virtually nothing against MAC, and they do nothing against abscessus. You got to have the macrolide for MAC. They help the macrolide, but they don't do anything on their own. So you don't typically see much improvement on ripe if this is truly NTM. Okay, Rocio, you're
Okay, and
social
so
listening.
some social listening, and these have been curated from some NTM support groups. Patient is saying, I'm discussing treatment plans soon, but I know it's long and painful. Typically I've got the strain that is the most difficult to treat. Though my underlying health is quite good, my baseline function is relative to when they're high 70s, and my doc says that eventually it'll decline. And I'm also a little worried because I'm not really eligible for transplantation should that day come. How often do you hear similar complaints? What are some of the, lack of a better term, bugaboos that your patients are bringing up as they approach treatment?
Well, I mean, I think that not knowing the age of this patient or how significant the disease is, I'm guessing it's Mycobacterium abscessus, since that's the most difficult to treat with the very low cure rates. But I would also reassure this patient that we don't know yet if they're progressing, and it looks like they have decent pulmonary function, and maybe they will decline. But at the same time, I think we're just starting. So I would first probably tell this patient that it's actually quite rare for us to transplant patients, and they really have to be pretty critical, and usually with an FEV1 like in the 30 range. So this patient may have a long, fruitful life and not decline or certainly ever need to have a transplant. But if it did get to that point where we are considering transplant in younger patients, it's not an absolute contraindication having NTM lung disease. So working with a center that's experienced, we've had successful outcomes.
Yeah. I would just add that there's a lot of bad on the street. I mean, people come in, they Google, they read stuff, and there's a lot of this where they just have a lot of pessimism based on what they read. And I try to emphasize the fun parts of treatment. You get to eat ice cream every night. I mean, there's certain things. It's not that bad. I mean, really, it's not as bad as people hear. They tolerate medicines better than people think. They're able to do longer courses of treatment more than what they Google and what they find. So I really try to emphasize that they're going to do great. And it's going to be hard work. You're going to have to take chronic medicine just like you do for your blood pressure, your lipids, or your diabetes, whatever. But you can do it because everyone else is doing it for those other diseases, and you're going to be okay, and it's going to make you better. That's why I tell people, I'm not lying. I'm trying to be optimistic and positive because I think if you present it that way versus, it's a lot of meds and they're going to make you feel like crap and blah, blah. I mean, that's kind of what people hear. They hear that from sometimes they hear that from their doctors. Yeah. I haven't been treated because my doctor told me basically what I just said. And you're like,
the treatment's worse than the disease.
Yeah.
Yeah.
I mean, how many times have you heard that?
Constantly. And in fact, I will say that sometimes, and what I'm going to say doesn't mean that I'm putting down support groups because I think they can be really helpful. But at the same time, there are certain support groups select for a particular population. And sometimes, given the heterogeneity of NTM-related lung disease, for certain patients, it can actually be more anxiety-provoking, and one has to be contextualized for the patients.
There's pros and cons. So this is a really nice downloadable practice aid that I think Shannon made, or Rocio made. Someone made it. You can go to that QR code and download it, and they'll ask you some questions about dinosaurs, if you're lucky. Managing and treating NTM lung disease. We are going to start with another poll. So QR that thing. And the question is, which factor most influences your decision to defer? So watchful waiting, quote unquote, is the term that's often used. Defer treatment. Mild or absent symptoms, risk of drug toxicity, patient preference, comorbidities, or something else. Yeah, that's pretty good. Lucia, do you have a reflection on that? The winner, mild or absent symptoms?
You're challenging my eyesight, Kevin, so I'm not sure you want me. I'm having a little trouble with fine print.
54% said mild or absent symptoms. That was the most common reason to defer treatment. That seems like a reasonable reason. How about, what do you guys think? I mean,
yeah, I would just say, when I first meet with patients, I explain to them that this is really not just a culture. It's not just their cough. It's not just the CT, right? It's a composite of all of those things. So when patients have mild or absent symptoms, and this was found incidentally, but then they have significant radiographic disease,
it's different. Yeah.
It's really can be a hard sell. I mean, it really does. And you have to spend the time to show them their CT scan, go through that with them, explain why in that particular individual you would want to start treatment. But I'd say for the majority of patients with mild or absent symptoms probably do have mild disease. And I would say that probably would be the most common thing that influences my decision to just, start with hypertonic saline and a positive expiratory pressure device.
Yeah, and I always tell people, I mean, look, if we had a 2-week therapy, we give it to you. Yeah, I mean, the bar for treatment is pretty high compared to other infections, right? A UTI, you just treat them. It's 3 days of antibiotics. So until we have, shorter course therapy that you have the ability to eradicate, I mean, you're going to treat a lot more people when you have those type of therapies, like we've seen in TB and with latent TB, right? It's, you're much more likely to treat someone with 3 months of rifampin-based therapy than 9 months of INH. So I think as we get better therapies, we might be tempted to treat milder disease. But for right now, I think there's a big chunk of folks that can be watched closely, like Shannon mentioned.
Absolutely.
So, recommended treatment regimens.
Yeah, so these, when we think about treatment regimens, I'm going to start with mild. So that's nodular bronchiectatic. And we recommend currently 3 drugs, azithromycin, rifampin, and ethambutol. And in our hands, we almost always use azithromycin because it is better tolerated, lower pill burden, less drug-drug interactions than clarithromycin. And you can, and it's very appropriate to treat these patients with intermittent administration, so 3 days per week. The exception to that would be someone that has severe disease or cavitary disease. We would not recommend intermittent treatment. So those are the patients who should get daily treatment with the oral agents. And we would also add IV amikacin for the first 2 to 3 months in those patients with cavitary lung disease. Now, if you're using IV amikacin, if any of you have used it before, you can appreciate how toxic it can be. So it is appropriate for the IV portion of that regimen to use that intermittently. And we will often dose that 3 days per week. And then refractory disease is its own animal. So in those patients, again, we would use daily treatment. And this was one of the strong recommendations in the guidelines to add amikacin liposome inhalation suspension or IV amikacin to those patients who are refractory. And refractory is defined as being culture positive after 6 months of treatment. That requires you to be checking cultures. That may sound very simple, but I can't tell you how many patients who've come to us and they said, well, I was on MAC treatment for 12 months. I was told to stop. And I said, was it successful? Sure, I felt better. I said, but did you get any cultures? No, never cultured on treatment. So you have to check cultures in patients that are on treatment, and we would recommend monthly cultures in those patients. So again, this gets down to how do you think about these patients? So the first question we ask ourselves is, are they macrolide sensitive or not? If they're macrolide sensitive, you go down the left side and you decide again, do they have cavities? You're going to treat with daily treatment and IV amikacin, or no cavities, they have milder disease, then thrice weekly treatment is appropriate. If you're dealing with macrolide resistant disease, that is very difficult to treat. So this is where we would add a prolonged course of IV amikacin out to 6 months and consider whether or not surgical resection is appropriate in that individual. Those 2 variables have been shown in research studies to significantly improve outcomes for those patients, because once we lose the macrolide, the cure rates go to like 5%. So you've really rendered your patient incurable. And I would be remiss not to channel David Griffith right now and say, please don't treat these patients with macrolide monotherapy.
Or a fluoroquinolone.
Or a macrolide and fluoroquinolone, because the fluoroquinolone doesn't work.
The only thing I'd add too is that you don't see macrolide resistance in someone who hasn't been treated before. So it's really the previously treated people where you're worried about that. Make sure you get susceptibility results before you start treatment.
Yeah.
I think it's really important.
Yeah, good point.
And also, one of the other plugs for really doing the surveillance cultures on these patients is if you have them on these non-suppressive regimens and you're not really even aware, and now it's month 10, it's month 12, they're still smear positive or culture positive, those patients also have higher rates of developing macrolide resistance. So it behooves you to really pursue and try to obtain that classification. And back to Shannon's original point, the contractual pieces with high quality supranational reference labs. I can't emphasize how many discrepant results we get when we send to some commercial labs versus University of Texas Tyler, National Jewish. We see a lot, and even with all the controversies around drug susceptibility testing, we'll see like an amikacin MIC of 2 at a commercial lab, and then we'll see an amikacin MIC that's 16. 32, and you're like, how is this possible? And so this is a big issue in day-to-day, our healthcare system that I think a lot of us face.
Yeah, I agree. Shannon, what about the outcomes of treatment-naive MAC?
So this goes back to the word cloud. Right? Bronchiectasis. First we'll start on the blue. That's the bottom, Kevin. If you have a patient on a 3-drug macrolide containing regimen and they're lucky enough to be cured, which is somewhere in this 50 to 80% range, anywhere from 25 to 50% of those patients will have recurrence. Now, recurrence is kind of the umbrella term. The details are, is that relapse or is it reinfection? And most of the time, it's reinfection. It's not a relapse of their prior infection. And why is that? Because they all have bronchiectasis. So they're vulnerable to getting reinfected again. In those patients who are not converting, so you get out to 6 months and you have not yet achieved culture conversion, this is the top part of the graph. This is where they would be a candidate for the amikacin liposome inhalation suspension.
So, as alluded earlier, this is really a team sport. We don't work in isolation. We work with our pulmonary colleagues, our thoracic surgeons, our radiologists, our nutritionists, our GI docs. This is really a marathon and not a sprint. The micro recurrence rates for MAC, as Shannon pointed out, are 50%. Does this patient really require retreatment? Does the patient need additional investigations? Are there other contributors to their clinical status and to their radiographic progression? We try to optimize all of the co-pathologies that have been discussed. We always ask, especially for refractory patients, is there a surgical option? And I can't emphasize how for the properly selected patient, surgery can really be life-saving and life-altering. The first patient with CF developed macrolide resistance in the context of this non-suppressive regimen. She was on thrice weekly for 3 years before she came in to see us in our center. So not only did she have macrolide resistant MAC, she had abscesses, aspergillus, etc., and document susceptibilities from reputable labs, as mentioned. For many of these chronic patients, we do often do therapeutic drug monitoring, at least in our center. I don't know, Kevin and Shannon, what your practice is in terms of TDM. And
we do it. I think the evidence is really most supportive for the macrolide drug levels, and that data has come out of Korea. So we do it. And, I would say we're selecting for patients that are usually treatment refractory by the time they get
Tertiary.
to us. So I don't know that it's necessary for every naive patient, but for someone who's not responding to treatment, I would suggest doing it.
Definitely. For a while, we did it routinely in everyone. And in our practice, about 15% had low ethambutol levels.
yes.
And it was more like 10% had low macrolide levels. So, I mean, it's definitely more common than I was expecting when I kind of embarked upon this little experiment. So I kind of tend to check it all the time. I don't check rifampin as long as they tell me their urine's turning color. I don't check it. But I often check it after being on drugs for 2 weeks. But certainly, like Shannon said, absolutely, if someone's failing to convert to culture, or they've relapsed, they converted, and then now they're positive again, definitely check it, because they may not be absorbing, they may have resistance.
For sure. The other group is if they have chronic kidney disease and you're worried about the ethambutol dosing, then I'll check those as well. And so this is really a roadmap. I think managing expectations, and this is sort of part of the upfront social capital that we all want to develop with our patients, is key. This is not the classical paradigm of 2 weeks of antibiotics and then you're set for life. This is really a revolving door. And so a lot of the time you spend contextualizing for the patient what this road is going to look like is actually it's actually really, really helpful in regaining that trust, because this is not something that's going to go away in 2 or 3 months. And let them know there are going to be rest stops. Some people require some drug holidays. There might be a detour. We may need to switch some medicines, but we are with you. And also incorporate their values, their goals, and expectations. If you have someone with a terminal malignancy who's in their 90s, even if they meet all the criteria for NTM lung disease, that's someone in whom you probably are not going to treat. On the other hand, you may have someone who perhaps has mild disease but is about to get slammed, so to speak, with adalimumab, and that's someone who has a different profile and a different risk situation. And then just be mindful that not all adverse effects are created equal, and make sure that patients have a way to reach you and your team. Incorporate all the other members of your team, because this is really an intensive situation. So I'm just going to go over a couple of things. We're not going to focus on the rapid growers today, but this is just to show some of the adverse effect management that we do for meds that are used for slow growers. Next slide. And so, as Shannon mentioned, I won't belabor this. Azithro is typically well tolerated, better tolerated than Clary. Azithro is more ototoxic than Clary. And then they're metabolized by the liver, so rarely we do see some hepatotoxicity, but overall, compared to the rates that we see in TB, much less. Ethambutol's role, there is synergy with rifampicin. It does play a role in protecting the macrolides. If there's a way that you can preserve that in the regimen, I'm sure David Griffith would appreciate that. These are studies that he did many years ago. Remember that just like the optic neuropathy that you can have with ethambutol, which more commonly occurs at higher doses or patients with impaired clearance, but can occur idiopathically, that we have to really educate our patients. And we know from studies that this toxicity can occur in between ophthalmologic monitoring. And so we always have to be very clear with the marching orders that if they are noticing, and we have a whole protocol of how often they have to check at home in between their off-the-evals, but if they are noticing a significant change, the protocol is, oh, I'm going to see you in 2 weeks, so I'm going to just press on. Even with strict instructions, and just not that long ago, when one of my patients decided to wait, even though she was told not to, and by the time the 2 weeks rolled around to see me, she was unable to see the highway signs. And so you really need to be very prescriptive about.
I'll just add to that. It's also very idiosyncratic.
Yes.
I mean, 2 points. I had a patient last week. She's been on a suppressive regimen with ethambutol and azithromycin for 7 years. And she's been fine. And I just checked a Ishihara on her because I asked her about her vision. She's like, I don't know. It seems like it's getting worse. It's always like that. I'm getting old. That's what she told me. And she got 12 out of 24. She should be getting 24 out of 24. I get 3 out of 24 because I'm colorblind. But she was definitely down. I sent her down to the neuro-ophthalmologist, and she's got neuritis after 7 years. I mean, so this is not something like, oh, you've tolerated it for a couple of years, you're going to be fine. You got to continually monitor these people. And I'll tell you, the risk is age dependent too. I mean, we did a study, and it was like 1 in 350. So I tell my patients, it's about 1 in 300, 1 in 400. It's probably a little, higher if you're younger. A lower risk if you're younger, 1 in 500, 600. But overall, in our population, our center, it was about 1 in 350. So, it's not uncommon.
Yeah,
and,
no, it's not.
You really gotta, and the other point is a lot of these people are older, and they don't monitor their vision very well, and they're having so many other problems affecting their vision all the time, and it's transient. It's really hard to get them to reliably tell you. So I'm very aggressive about color testing monthly at home and every visit. I don't know about you guys, but
yeah, for sure. And you can get free apps if they have smartphones, and it's actually not difficult to do that testing. Rifampin is our problematic child. This is the one that's most likely to get people into trouble. And of course, the GI intolerance, the flu-like symptoms, nighttime dosing often helps. And please be prescriptive and granular. Patients oftentimes have the desire to split dosing, but remember, all of these NTM meds are concentration-dependent killers. And so splitting dosing may make the patient feel better, but then you don't get credit for the use of the rifampin, and so you have to be very prescriptive. Clofazimine, many of you will, if you need it, and if you're not associated with a multi-patient IND, you have to petition the FDA with single-patient IND. The hyperpigmentation and xerosis, dry skin, is very common, and then you always educate about the scary side effects. You do monitor the QTc, rare intussusception. Bedaquiline will present some data tomorrow and Tuesday at one of our poster sessions. Follow the QTc, especially many of these patients are on additional QTc prolonging regimens to be honest, the hardest thing with bedaquiline is actually getting it approved. And then with linazolid, peripheral neuropathies, the cytopenias, and the mycobacterial dosing is half the dose. And there's data from MDR-TB that now you can do like 3 times per week for drug-resistant TB. And for NTM, it's typically daily. Amikacin, we know that there's more toxicity with IV than with the liposomal forms, but inhaled amikacin, about half of patients will develop some type of respiratory and or dysphonia, hoarseness. There are several strategies that can be used, including if you develop the hoarseness and it's severe, you pause, and then you can restart it 3 times per week, and then you can slowly reintroduce up to target dose. About 3% of patients can develop a alveolitis or an interstitial pneumonitis. Kevin, do you want to comment on that? I know you're on some of these studies.
I just tell my patients with ALIS or ARIKAYCE, I mean, it's a rule of 50. 50% tolerate it without a problem, like totally fine, no problems. And about 50% have problems. And then of that, 50% of those problems are solvable by, infrequent, intermittent dosing and, albuterol inhaler before. I mean, a number of other things we do. So I have pretty good luck keeping people on ALIS. I'm a big intermittent doser, which I know is not the label. But, we dose IV amikacin intermittently. And if you think about the killing characteristics of amikacin and mycobacterial growth characteristics, intermittent therapy makes a lot of sense to me, and particularly if it allows you to tolerate things. So I often start thrice weekly with ALIS, and then I titrate up, but I usually don't go more than 5 times per week. Everybody likes to have a weekend off of no matter what they're doing. And I know that's not the label, that's not the recommendation, but I mean, I'd rather have someone on it and benefiting from it than blown out of it and quitting it. So I don't know what you think. But.
Well, I guess I would also just comment that, and this was in the study, that most of those patients who you can, get back on treatment, whether or not that's 3 times weekly or daily, the side effects will significantly improve by week 4 to 6. So that, 50 to 80% number goes down to about 5% in the CONVERT trial.
Yeah. Yeah. That's why I like to start intermittent, because I think rather than you start every day at the get-go, you lose all those people. They quit. They're like, I don't want to do it.
Yeah.
If I can start slow and gradually titrate them up, I think I have a better chance of keeping them on treatment. I don't have data to say that. I guess that's my personal anecdotal experience. But
we do that too, because we've noticed, during that 2017, 18, 19, we had patients who were straddling both the inhaled compounded version and the inhaled liposomal, and there was a proportion who would ask me, can I go back to the other one? And I would say, no, let's try to manage you so you can stay on this. And so you really want to get them engaged in the marathon. It doesn't do you any service if everybody quits.
We'll show you some of the data coming up. I think you have a couple.
Yes, and so I'm almost done. So staggered introduction. We don't throw everything at once. Nighttime dosing, in particular for the rifamycins, can be actually quite helpful. Beware of split dosing, as I mentioned. For patients who are really struggling with their GI tract, really be aggressive about making sure that they stay hydrated, and also be aware of concomitant SIADH. A lot of people go crazy and they start pumping in 12 glasses of water and their sodium is like 120. And then TDM can be useful in certain scenarios. Sometimes with rifampin, if you have very, very high doses and patients are very underweight and you're sort of pushing into the mid-20s, those are patients who actually may tolerate a dose reduction. And then some patients just really need a little time off, get themselves together, and then we restart with a different mechanism, and or we may sometimes have to switch out the rifampin for the clofazimine, et cetera. And so but if you let them know in advance that this may happen, you're much more likely to get them to sort of say, okay, yes, you did warn me that there was a 10-15% chance that we might need to do something a little different. I'm not going to talk about this. This is just for your slides. And so, Shannon.
So, I just commented on this a moment ago. This was one of the strong recommendations that came out of the 2020 guidelines, that in those patients that are culture positive at 6 months, we recommend the addition of amikacin liposome inhalation suspension rather than just continuing with their standard regimen alone. And that was based on this study where you already see the separation between the treatment arm and the guideline-based therapy arm by month 1. And out to month 4, there was 29% of those patients in the treatment arm who were culture negative versus 8.9% in the control arm.
So what other strategies can we do to actually enhance the quality of life of patients who are living with this chronic disease, especially those on treatment, that you like to use?
Well, I think, again, I mentioned this earlier, but I really think that those patients who are underweight don't do as well. They usually progress, and that's a significant risk factor for progression of their lung disease, but they also have a really hard time tolerating treatment. They have, in my experience, more GI intolerance than those patients that have a normal weight. So we work very closely with our nutritionist. We talk a lot about appetite stimulants in our program. So we'll think about things like Marinol, mirtazapine, Megace in these patients. You do have to be mindful of QT prolongation with the SSRIs. But it is, it's certainly doable, and patients just feel better. They have better energy levels when we're able to restore their weight.
Yeah, I had a little old lady bring me some pot brownies recently. I didn't accept them, but that's what she's using for her appetite stimulant, and it seems to be working. She's gained 5 pounds. So the thing I'll just add too is rifampin. You didn't get into it, but the drug interactions can be a huge issue with rifampin, as you guys know. So sometimes you can't use it. Everyone's on an antiplatelet drug. It seems like these days you can't use rifampin.
Yeah.
So you
Or their
got
hormones or their thyroid replacement.
So you got to come up with either you're going to stick with the 2-drug regimen, or you got to come up with the third drug, which some of the ones were mentioned there. Polling, I think we're almost to our last Mentimeter measurement. What's your approach when a patient relapses after standard therapy? Restart same regimen, modify regimen based on drug susceptibility, refer to a specialist, unsure or case dependent. That seems like it's always case dependent. It's probably good. Shannon, do you agree with that as the winner? I think you already mentioned
I think you
before.
nailed it when you said it's very case dependent, right? So is it true relapse? Is it reinfection? I'll just start with the reinfection piece. So, in a patient who's been treated successfully, we've shown that they've had 12 months of negative cultures. They've been off treatment. We're monitoring them because, again, this is continuity of care. We don't discharge patients from our program. If they have disease again, we start over. We look at drug susceptibility. We, make sure, is it the same species? Oftentimes it's a completely different species of MAC. Maybe they had avium 3 years ago and now they have intracellulare. And it doesn't mean that you have to start that patient on daily treatment. You don't assume that they failed because this is oftentimes a new incident infection. So you just look at the patient. If they have mild disease, we'd start them on thrice weekly treatment.
I agree with everything there. NTM strategies and outcomes. We talked about watchful waiting and continual reassessment. We talked about treating with antibiotics and risk factors for progression. I mentioned the bar to treatment is relatively high. We don't have super quick eradication type therapies, and wish we did. We're all working on those. Treatment duration can be long. The side effects were mentioned by Rocio. And culture conversion is relatively high. If you can tolerate a macrolide-based regimen, it's probably 60 or 85%. And then Shannon's talked about relapse and reinfection. So last couple slides, main barriers to adherence to treatment and how can we better address this? We've talked a lot about that. Do you guys have any other thoughts about
No, just
adherence or...
The only thing I will say also impacting adherence, side effect management is access to drugs, especially for refractory disease or co-infections. Those are becoming more and harder especially with the evolving insurance landscape.
Right.
So-
We really didn't talk much about Mycobacterium abscessus, but usually when we're done with the talk, all the people who come up are going to ask
have
us about
abscesses.
Mycobacterium abscessus
Yes.
because it is very difficult to treat.
Yes.
It's very difficult to find drugs that have activity that aren't toxic in IV. And then when you do identify drugs such as bedaquiline, tadizolid, omadacycline, things like that, their copay is
Can't get
just
them approved.
a barrier to access. So it's quite challenging. So tell us what's coming in the pipeline.
Yeah, so the pipeline is kind of on the slide. For abscessus, we just reported a very positive phase 2 trial, and that'll be a presentation I'm giving tomorrow morning, actually. So please, if you're interested in omadacycline, we saw really high rates of culture conversion with omadacycline monotherapy in 3 months against abscessus. It's not to say that that'll be the new therapy, but it was a proof of concept phase 2 that shows that it works. Refractory MAC, there is an inhaled clofazimine trial, which if you have refractory patients, think about referring them to a center that's doing that trial. There's a couple special, bedaquiline's under study in Japan, delpazolid in Korea. For MAC, the real exciting study is the Insmed study for liposomal amikacin, where we're using it at the very start with azithromycin and ethambutol, and we're trying to see if it shortens treatment duration and improves response. And we'll have a slide on that in a second. We have an inhaled hypertonic saline study, which for mild disease, that may be enough, as Shannon was saying. We also just completed a monotherapy trial with clofazimine, and there's a 2 versus 3 study. Some of us don't believe rifampin probably adds much to the regimen, and so that was the question being studied by this 2 versus 3 study, which completed enrollment and will report out in September. So thank you for those of you in the room that helped with that one. There are a couple other drugs out there. Epetraborole, I should mention, is still out there. We don't really know where it's going to end up. There's a few other drugs in the pipeline that are planning phase 2. So I think there's more to come, and I think it's an exciting time for the field and for patients. Next 5 and 10 years, they'll have longer or better options. This is a trial I just mentioned with ALICE, and using ALICE in combination with azithromycin and ethambutol at the get-go. So these are new treatment starts. They could be naive or they could have recurrent disease, but this is a new treatment episode for them. Normally, we'd put them on the 3 drugs that were mentioned. Sometimes mild disease, we'd do just 2 drugs, or if you can't use rifampin. But this was really to see if ALICE being added to azithromycin and ethambutol improved outcomes. And this is preliminary data. This was the interim data cut from one of the studies, and it was very encouraging. And it showed that by month 7, 78 or really 80% of the people in the ALICE arm were culture negative and had converted, whereas in the comparator, it was only 47%. So quite a bit of improvement. What's not depicted in the slide too, but was also reported, was the time to conversion was much sooner. So we're seeing these people convert their sputums after 1 month of therapy, which is really exciting because it means, I think, when the study's done, it's going to suggest, I hope, that we can treat people for less time, right?
Yeah, and these patients stopped treatment at 6 months.
Yeah.
So you're seeing that real disparity after they came off treatment for a month.
Yeah. So we'll see. The main trial is a 12-month therapeutic time period, and they're measured kind of month 13, kind of, again, a month after they've come off therapy to see where they're at. So, Shannon mentioned we do try to treat people 12 months after culture conversion. So if you can get them converted sooner, you can stop their treatment sooner. And that's, I think, a big win. If you tell patients that, they're pretty excited about that.
It's incentive to check cultures monthly.
Yeah. So I think the last time polling, which dinosaur best matches your clinical style? Ankylosaurus, tough, grounded, always protecting the team. Paracephalus, communicates clearly. Tyrannosaurus, unconventional. That's what I am. Oh, and we have some questions. Yeah, oh boy, we have a lot of questions. Okay, and we have just a few minutes. Finished up a little early for questions. That's good. I like the iguanodons, steady, reliable. That makes sense to me. Okay, let's go to questions. How do you differentiate between reinfection and relapse? You touched upon it, but how do you really tell?
Well, if you really tell, it requires, a molecular lab that's you're either doing whole genome sequencing on the isolate or some other molecular method, which isn't practical in clinical practice. So I think what we have that's available is looking at the species level. But unfortunately, that's, doesn't really give you the answer. So
We use a little trick. The University of Texas Tyler. So we send actually all our new isolates. We send Sensi's to Jewish, but then we send a Naliquat to Texas. We do a bedaquiline MIC, and they'll store it. And then if in a couple of years after they've achieved their culture conversion, they have their micro recurrence, Texas will still have that frozen. And so we've been able to detect a lot of reinfections through that mechanism, but that is not something that is widely done.
Mm-hmm.
Good question about, we were talking about testing for CF. What about PCD? Do you test for it, and how do you do it?
Yeah, we have a genetics clinic, which has, unfortunately, a very long wait time. There used to be access through, I believe Invitae was running a study through Chris Richards, and we were able to get a lot of our patients tested through that mechanism, and now that's folded in. And so there's some out-of-pocket costs. I don't know how National Jewish does it.
So if we have someone we're suspicious, we'll start with a nasal, nasal NO, nitric oxide level. So this is different than an exhaled NO. It's a nasal NO. And if they're low, then we'll definitely send genetic testing. We don't have a genetics clinic at National Jewish, so that's something that I think we would really benefit from. We will often use our partners over at University of Colorado. But typically, if we're really suspicious, we'll do all three. We'll look at a nasal NO, we'll do a scraping, look at EM of the cilia, and then we'll also send off genetic testing.
Shannon, do you want to comment on the use of molecular diagnostics on sputum? No?
Not really.
I mean, we don't use them. Did any of you guys? Yeah. I mean,
routinely for clinical practice.
Yeah, not routinely. I mean, I think there's research questions there, and there's potentially some tests that might be useful at some point. But right now, we don't do that. Rheumatology. Oh yeah. Well, this really speaks to high risk patients. A rheumatology patient starting a biologic TNF blocker who has bronchiectasis on CT and a positive AFB culture, but no symptoms, and would you treat them anyway? My answer is yes, I would. If you can't get them to avoid the TNF blocker, that's the kind of patient I kind of treat, even though they may have minimal symptoms or minimal disease, but I don't want them to progress because I think the risk is high. Would you agree with that?
Completely. And it's a nightmare when they disseminate.
Yeah.
Are you seeing more NTM with the increased use of ECMO?
I don't know the answer to that.
No. Yeah, I haven't. No. In your experience, how frequently have you seen NTM secondary to CPAP use? Well, we did talk about that. Definitely seen people who, like, to me, the classic is they're isolating MAC or something else. Their CT scan's totally normal, but they always isolate the same bug. Yeah. And I say, oh, do you use a CPAP? Yeah, I do. And this is how I clean it and blah, blah, blah. Anyway, you get them to clean their CPAP right, and it goes away. I mean, I've had a number of patients like that. So I don't know what you guys think, but yeah. Can you confidently diagnose NTM lung disease without access to advanced imaging or microbiology labs? No. You can't. You have to have those things. Lastly, Shan, this is for you because you're an gene expert. What is the role of the gene? Tell us about T's and C's and what that means to you.
Okay, I'll try to keep it basic in the interest of time. So abscessus, one of the reasons why it is so difficult to treat is its resistance to the macrolide. So about 80% of the isolates that we see here in the US, it's very different if you live in Korea, for example, but 80% of what we see is Mycobacterium abscessus, subspecies abscessus. It has an gene, which is a methylase gene that confers inducible macrolide resistance. So historically, we used to use a 3-day read on the microdilution wells to tell you whether or not the macrolide works. But around 2009, we appreciated that, in fact, one of the reasons why abscessus is so difficult to treat is that if you hold those wells out to 14 days, all of a sudden the organism's growing. And that's because of this phenomena of inducible macrolide resistance. So you have to know the information that your lab is giving you. And fortunately, a lot of the commercial labs now will have a footnote below the MIC to say that this is based on 14-day incubation. That's all you need to know. You don't need a molecular test to tell you, do you have an ERM gene or not? As long as they are giving you the phenotypic results that they have inducible resistance, then you know that the macrolide is not going to be a drug that's counted in that individual's regimen. You can still use it. You're using it for its immune modulatory properties. Now, the little light at the end of the tunnel is that some of those patients with Mycobacterium abscessus, subspecies abscessus, and it's around 15 to 20%, will have a mutation in that ERM gene. And that is at position 28. And so we call those C28 sequivars, meaning that they have a cytosine. And we love to see that. But again, you don't have to have a fancy molecular lab to tell you that. You just need to know what happens at 14 days. So if at 14 days it looks sensitive, maybe there is C28. The bottom line is that the macrolide works. And their cure rates, if they're sensitive to macrolides, 88%. Versus 23% if they're macrolide resistant. So dramatically different outcomes in those patients. So we are all, we need to know what we're dealing with because it significantly impacts the prognosis in those patients.
We just have two more questions. That's it. What models of care or resources exist for managing NTM lung disease in rural or underserved populations with limited access to specialty care? Rosia?
I might bring up the COPD Foundation Bronchiectasis CCN network, which is funded by the COPD Foundation. It really wants to increase access and support to clinicians. And I encourage any of you who are working in both smaller centers where you might apply for sort of the affiliated status and linking also to the larger centers. This is really meant to increase access. I don't know, Shannon, if you have any other comments.
Yeah, I mean, the goal is that we can incorporate 150 centers across the U.S. over the next, I think, 3 to 4 years. We had 33 sites that were approved, and a lot of those sites are sites like National Jewish or Mass General or OHSU that are doing this. But we really, if you're in an area where you're seeing NTM, we would encourage you to go to the clinical care network, the Bronchiectasis and NTM Association, and understand what that would involve to be an associate center as opposed to a care center.
Yeah, the only thing I'll add is write your senators and Congress people because for me, it's virtual visits and I see patients 5, 6, 8, 10 hours away virtually. And that is going to go away in September. Medicare will no longer be paying for that. And your patients are going to lose access to specialty centers and experts in this and other things. So I'd encourage you to make your voices heard on that. Last question. Was there one more?
Or a couple.
Yeah, this is not a good question. No, I'm just kidding. Would you consider treating disseminated NTM without full speciation in a patient who's critically ill? No, I don't. I can count one time I've treated disseminated NTM empirically. I mean, you can, but it's almost unheard of.
So just without speciation, you have mycobacteria growing?
Yeah, but you have no idea what it is. Yeah.
Mm-hmm.
It's kind of tough.
I guess it depends on how sick the
depends
patient
on how
is.
sick.
Yeah. I
It's
would
just
probably
an
start
onerous-
them on a broader,
like 5-6 drug, and
Yeah.
then hope that you don't get a ping by 14 by 10,
I mean,
14
it's pretty
days.
unusual because usually you can get a species pretty quick. Like you
Yeah.
can probe
Yeah.
it and know in a day it's MAC or
Yeah,
not, right?
Exactly.
So the most common cause of disseminated NTM is MAC. I mean, and then other rapid growers like abscessus.
Yeah.
I think that's probably it. Actually, this is pretty good. You treated MAC, they cleared, they got better, stopped the treatment, then they grew abscessus, but there's no CT changes and they feel good, but they keep growing abscessus without progression on their CT or symptoms. What would you do? You already mentioned it.
Just watch them.
Yeah, I agree.
Airway clearance, airway clearance.
Last one, in TB high burden countries, Rosia, you spoke to this. TB bronchiectasis should be kept in mind as a risk factor. I think you mentioned
Absolutely, yeah, for sure. Up
I think
to
that's it,
75%.
guys. I'd encourage you to take this QR code home with you and find out what kind of dinosaur you are tonight.
Thank you.
Thank you.